All right, here we go. Episode 3. We're going to be talking about the meniscus today. And I've got one of my colleagues, Dr. Steve Jones, with me. He is one of our new partners, sports medicine trained. And so, Steve, usually what I do is I start things off with an introduction.
Sure.
Okay. All right. So, Dr. Jones, med school at Tulane down in New Orleans and residency at the University of Colorado, and then fellowship, sports medicine, shoulder, all that kind of stuff out in Stanford. So really well-trained guy. And we're talking about the meniscus today. All right?
Of course. Thanks for having me.
You just got out of the operating room too, though, by the way.
I did, yeah. Trauma case. Always fun to get some of those mixed in with our sports medicine practice.
You weren't fixing a meniscus, though.
I was not.
You're not fixing the meniscus.
Would prefer to be doing that.
Yes. Okay. Well, there's a lot of menisci to get fixed around here. So, hopefully with this episode, we're going to talk about the meniscus. We're going to go over hopefully most stuff, and then really get everybody understanding, about the meniscus, why it's important, and all that kind of thing. Okay.
Awesome.
So let's start off. So just tell me what's the meniscus?
Sure. So the meniscus is it's a fibrocartilaginous structure that kind of lives between two bony surfaces, and most commonly we think of the meniscus in the knee, and that's what we'll talk about primarily here in this interview, this conversation. But we have kind of these menisci, plural, all over our body. We have one kind of in some of the joints around our chest. We have one in our wrist. But again, the one that we kind of most commonly think of are the two that are in the knee. If you want to think about it in its most simple terms, it's a shock absorber. It's a structure that acts to improve lubrication and friction between two bony surfaces, and in the knee it actually offers some stability as well. It's kind of like a rubbery C-shaped structure, and it lives between the thigh bone and the shin bone. You have one on the inside and one on the outside, and it's a very important structure. A lot more detail that we'll get into, I'm sure.
Yeah. So the way I think about it is, or I think most patients are able to understand it with two ways. One, I just call it a shock absorber.
Yeah.
It sits between the thigh bone and then the shin bone, and it just sits there and absorbs load. Just the thigh bone and shin bone are just going back and forth like this. But also, like you said, it helps with stability, right? Mm-hmm. And like a chalk block. Like if you put one of those things behind the wheel of your tire, like it keeps the car from rolling. And so if you think of the thigh bone on the shin bone, if that meniscus is sitting there like that chalk block, that might help with the knee shifting, stability wise, right?
Absolutely. Yep. Good
Gotcha.
analogy.
So let's talk about like the actual mechanics a little bit more. So one thing that happens a lot, or you hear the term a lot, is treating meniscus tears. Mm-hmm. But it seems like you have to understand the mechanics to understand, what the right treatment might be.
Absolutely.
And so tell me a little bit about that.
Sure. Well, kind of to keep going into the, idea of what the meniscus is. So the word meniscus, it comes from a Greek word meniscos, which means crescent or kind of semilunar. And that's very important. That shape is kind of what gives the meniscus its ability to do what it does. So our knee, which we have some awesome models here, and I won't pull it in too much, but kind of the end of the thigh bone kind of has two bulbous ends, the condyles. There's one on the inside and one on the outside. And the top of the shin bone sort of has two sides that correspond with those two condyles, so to speak. And there's a meniscus that lives between the inside part, medial, and the outside part, lateral. Because the meniscus is sort of C-shaped or shaped like a half moon, like a crescent, it acts to, one, like we've talked about, absorb force. So each time we step and we transmit load through our knee, the femur or the thigh bone and the shin bone kind of want to come together, right? Gravity is pulling us down to the surface of Earth, and the two bones are wanting to touch together. Well, because you have this, again, C-shaped or semilunar-shaped shock absorber between the two, and again, the meniscus is kind of a squishy, it almost feels like a piece of rubber, like kind of a dried piece of rubber or so. As you step, the meniscus can kind of bounce. It's almost like we call it hoop stress, like a hula hoop, but really it's able to accommodate and transmit load in a more even way across the knee. Secondly, as you just brought up, the stability portion of the meniscus is critical. So because the meniscus is attached to the shin bone on the front and the back, as well as some attachments to the soft tissues around the knee, as the knee goes into flexion or into a bending position, it actually acts as that kind of that chalk stop, the same analogy you used with the car. It can provide some resistance to both anterior, posterior translation and rotation. So those are two, obviously really, really critical components. Lastly, there's also some evidence that it actually improves gliding, reduces the coefficient of friction, and keeps the knee moving smoothly. One fun fact, healthy cartilage on healthy cartilage has a lower coefficient of friction than ice on ice. And so when our knees are in their most healthy state, it should be almost kind of the most pure gliding you can ever imagine on the inside. And the meniscus plays an important role with that.
Yeah, I actually didn't know that. The coefficient of friction, ice on ice. That's interesting.
Yeah.
I mean, you can just kind of like
healthy. It has to be healthy cartilage. Obviously.
Yeah, healthy cartilage. Like when you feel it, it's like it's super smooth. And but that's a really interesting point. You talked about where the meniscus attaches to the front and the back of the knee, and so so maybe let's use that segue about to talk about maybe some of the types of tears you might see, because the tears can involve different parts of the meniscus, and they can involve some of those meniscus attachments. So what are some of those tear patterns that you can see?
Sure. And so again, think of the meniscus as a three-dimensional structure, because that's exactly what it is. So again, using the same C-shaped analogy, so to speak, the medial meniscus is a little bit bigger, so that's kind of here in my left hand, and the lateral meniscus would be a little bit smaller. My index finger and my thumbs would be the locations of the attachments, and so we call those roots. There's one in the front of the knee, the anterior root on both sides, medial and lateral, and then one in the back, the posterior root. Because the meniscus is a three-dimensional structure with two attachment points, you can have failure or pathology or tearing in any kind of different way, shape, or form. Some of the tears we see, kind of one of the more common types of tears, is if the meniscus is just torn vertically through the body. We call that a vertical tear. And basically it would be like me having the meniscus like this on the table and kind of taking a knife and going up and down through the meniscus like this. That's one type of tear. Another type of tear is a horizontal tear, where we take the meniscus like this and it almost unzips from the middle, and it creates two leaflets, one above and one below. A more concerning type tear, and we see these frequently, are radial tears or oblique tears, and those just go straight through, almost taking the letter C and cutting it right down the middle. Those are obviously quite concerning because the ability for the meniscus to provide shock absorption is now disrupted. If you imagine every time you would step, and if this meniscus is cut in half, those two ends are just going to want to splay apart each time the load is transmitted through the tissue. So these are different types. And then ultimately the root tears, which are also kind of bad actors because they lead to the same problem. If I remove my thumb attachment or my index finger attachment from the back or from the front, now the meniscus can just kind of slide out, what we call extrude, from between the thigh bone and the shin bone and lose its ability to transmit load, provide friction reduction, and shock absorption. So those are sort of the worst actors. But all meniscal tears are different. It's probably like a fingerprint. They have similar, profiles. They have some concepts that we can kind of use to describe how they are, but in terms of ability for the tissue to heal, where the tear is located, how extensive the tear is, how acute versus chronic the tear is. I mean, even in the same patient, same knee, every tear is different. So it's a wide spectrum that we see.
Yeah, that's great. That's a great summary. And what I feel like I'm seeing more of these root tears or this extrusion phenomenon, and going back to analogies to help patients understand, I will use like if you hold a bar of soap in your hand, and it squirts out.
Oh yeah.
Hand. So like if I'm trying to push a bar of soap in between my hands, like a wet slippery bar of soap, and so if you're walking and you're putting that compression and that bar of soap slips out, that's like the extrusion you talked about with the root, huh?
Yep.
So I just wanted to throw that in there. That's a great analogy.
I use the tube of toothpaste, but that's way better.
Okay.
The bar of soap,
yeah,
because the soap will actually fall out. So
yeah, so that's what I use. But so definitely the different types of tears can make a big impact on their biomechanical properties and can cause. Some aren't so bad in terms of how much load the cartilage of the bone feels. So let's go to that for a second, because the meniscus is actually made of cartilage, a type of cartilage.
Exactly.
But then there's also cartilage on the ends of the bone, and they all shock absorb and have low lubrication. But we're talking about the meniscus essentially protecting the cartilage on the ends of the bone, right?
Absolutely.
Okay.
And we know that from, long-term historical studies. So I believe in the late 19th century, the late 1800s, we started to get a little bit of a better understanding of the meniscus, where it is and what it does. And I believe the first meniscus repair was sometime in the 1880s maybe. Now that research has gone on, we've learned the incredibly important role that the meniscus plays in protecting the cartilage. There are numerous studies that show patients with complete meniscectomies, which means meniscus removal, patients that have no meniscus over a course of 5, 10, 15 years, they can develop pretty significant and fairly rapid arthritis. Now that, obviously plays with things like alignment and activity levels and, obesity and weight. But for the most part, if you don't have a meniscus, the cartilage in that aspect of your knee is going to take a hit. It's going to be loaded abnormally. The contact pressures are going to increase. Again, the friction is going to increase, and that can lead to arthritis, essentially osteoarthritis, which is breakdown of the cartilage in our, simplest sense of the word.
Yeah, and so that's really how I think about it. And when it comes to treating the type of meniscus, the treatment really depends on a lot of times. I mean, not all the time, but a lot of times on what effect that type of tear is causing to the cartilage on the end of the bone. So when you talk about like the root tear, and if you tear the root, the whole thing's shot, right?
Pretty much. I mean, again, if the root's entirely torn and the meniscus is starting to extrude out, its ability to transmit load and provide shock absorption,
there's just nothing there.
It's gone.
There's nothing in between. It's not that it's gone, but it's just not sitting between the bone. Right.
Exactly.
It's like if the shock falls out of your car.
Totally.
And it's just like,
it's
bang.
still there on the ground,
or maybe,
but it's not doing its job.
Maybe it disconnects from the top part of the car. It flops out, and then the car is still banging.
There you go.
Yeah,
exactly.
It's still technically attached, but it's not doing anything
exactly.
at that point.
Exactly.
And so the root tears are like that. And then the radial tears are similar, right? Mm-hmm. They can do a similar thing.
Exactly. And again, it exists on a spectrum. So small radial tears that don't go all the way to the periphery, those may not have as much of an impact on loading and force transmission, but complete radial tears that go all the way out to the periphery that lead to the two sides of the meniscus separating, the ability for it to provide shock absorption and appropriate load transmission is going to be really compromised. And again, we have studies that show, the lateral meniscus is a bit more important than the medial meniscus in terms of that. The lateral side of the knee is a bit more rounded, so what we call convex, whereas the medial side of the knee is a bit more bowl-shaped, so a bit more concave. And in general, the lateral meniscus is a bit smaller than the medial meniscus, and so you have this kind of rounded joint aspect at the top of the shin bone with a small meniscus on top. And if that meniscus is, again, if there's a root tear or a complete radial tear, I mean, the contact pressures can increase 200, 300%. I mean, like 2 or 3-fold, which is not good for the cartilage, especially in a young patient. So,
yeah, I always thought that the anatomy on the outer side, the lateral side of the knee, was interesting because, like you say, you've got the concave, which is like a ball. And then you've got
convex ball, right?
I'm sorry, yes, convex. Thank you. So convex, and then the femur, the thigh bone part, is also convex.
Right.
And so you've got essentially two balls on each other with point loading right there. And without the meniscus sitting there, you have a smaller contact area which focuses the force on the cartilage, and you can imagine what happens at that point.
Absolutely.
That all starts wearing out. Yeah.
Right.
So two bad actors, the root tears, the radial tears. Briefly talk about the really common older quotations, maybe late 40s, 50s, 60s and up, these degenerative type of tears. What are those like?
Sure, yeah. When we think about meniscal tears, at least in my mind, and I think a lot of surgeons' minds, we separate them into sort of the acute versus more chronic categories. In our kind of 30s, 40s, 50s, and older patient population, patients that have been very active, if they've worked, labor type jobs, really anything that's led to some demand across the knee, we tend to see these more degenerative or wear and tear type meniscus tears. And I don't know if we truly understand the primary risk factors that lead to it in terms of, ignoring the ligaments and things like that. We'll get into that in a little bit. If you have a ligament deficiency, you'll put more stress on the meniscus, and alignment issues as well. But ignoring that, assuming a patient has normal ligaments, normal alignment, for whatever reason, we do in certain patient populations see that they have these types of meniscal tears on MRI, and even that is has to be taken with a grain of salt because we're diagnosing a lot of these on MRI alone, and on the MRI we're just looking at lines of gray, and it's sort of, it's how big is the tear and how extensive it is. It's hard to say. But certainly those types of patients can present similar to acute tear patients. They have pain, they have swelling, they can have mechanical symptoms, which we kind of consider catching and locking or painful popping inside of the knee. And again, depending on the type of tear, those symptoms can be more or less severe. They can be more frequent or less frequent. It just, again, it exists on a spectrum, and certainly not every patient with a meniscus tear needs or would benefit from surgery because there's such a big variety. But if they've failed non-surgical treatment options and they really have reached the end of the line, it's not an unreasonable thing to consider.
Yeah, I think with those degenerative tears, I find that I'm taking more of my time explaining that is not the source of their symptoms,
right?
For the most part, because they have arthritis in their kneecap joint or something like that, and that it can get confusing on the report, because honestly, most reports, it seems like 50, 60, 70, there's going to be a tear, quote unquote, a tear somewhere in the knee,
right?
And you just gotta. I was going to ask you about like symptom presentation. You touched on that, and so it's in my experience. You really have to clarify where some of these symptoms are coming from, or you can get in trouble.
Absolutely.
I've actually got a story about that too.
Well, good. Well, I'll just add. So the kind of the classic example that I'll see is, and like you kind of alluded to, so patients in their 40s and 50s, if we were to go out and MRI 100 patients in their 40s and 50s that have no knee symptoms at all, a fair number will have signal in the medial meniscus, which can be read as a tear on an MRI. And because of that, you always have to, like you're alluding to, tease out where a patient's symptoms are truly coming from. So if I have a mid-40s patient that comes in and they have pain on the outer aspect of their knee, and let's say they're referred to me by their primary care doctor, and they come into my clinic and they say, yeah, doc, I got pain over here. It's on the outside part of my knee. It hurts when I walk. It hurts when I go up and down stairs. It kind of runs up and down my thigh. It kind of burns a little bit depending on how active I am. Their primary care doc orders an MRI, and the MRI comes back as a posterior horn medial meniscus tear, and it may say complex, it may say intrasubstance signal that may be read as a tear. Then they come to our clinic and they say, hey, I have a meniscus tear, doc. They hand us the MRI report and say I need surgery. And so when you get to talking to them, though, you realize that the pain's coming from the lateral aspect of the knee, but they're the MRI shows a medial meniscus problem, which is on the opposite side. And that's not to say that sometimes pain can be referred and every patient's different, but for the most part, if you have a true medial meniscus problem that's creating symptoms, your pain's going to be the inside part of your knee. And that's just common things being common. And so, and that patient, for example, they may have something like IT band tendonitis. And the IT band's a big tendon that lives on the outside part of our knee, outside part of our thigh, and it can become flared up quite easily if if you suddenly increase your activities. And so that patient for the last 3 weeks, after getting their MRI report, maybe thinking, oh, I have a medial meniscus tear, I need surgery, this is going to be an easy fix. But it turns out it's something different, and it's just physical therapy. So it's just a matter of clarifying and ensuring that you know what actually is driving their symptoms, because that's our goal, is to get patients better. We treat patients and not pictures, and that's a really important thing that I harp to patients.
Have you heard of the mnemonic BARF and vomit?
No, I don't think
BARF?
so.
Okay, so BARF stands for the brainless application of radiological findings.
Oh, that's great.
And VOMIT stands for victim of modern imaging technology.
Wow.
And
I'm surprised I haven't heard of that. It's amazing.
I'm going to credit to Dr. Brian Cole at Rush University for that, who taught me that. Well, either he told me that or I saw it in a presentation. So amazing. That's where I heard it. Maybe he heard it from somewhere else, but I don't know. But
it's incredible.
I love that. Yeah.
And credit to our radiologists out there. They have a hard job, right? The radiologists they're going through a ton of imaging. They are, going through these extensive, multiple different sequences, multiple different, angles of cuts that we see on the imaging, and they have to be diligent. So anything that they see or find, they have to comment on, and it's appropriate because they catch all kinds of stuff, right? I mean, radiologists are a crucial part of our healthcare system, but at the same time, you spit out this long list of findings, and now that the medical record is transparent, and it's probably different system to system, but here at our hospital, our patients can see their medical record, and so they can have the access their own imaging reports, and that report is typically written for another provider, not necessarily for the patient. And so it just kind of creates a challenging conversation. They have all these findings in their knee, but it turns out it may be something not even on the MRI that's causing their pain.
Yeah, definitely. One of my personal stories is a patient came in, and I thought she had pain related to her kneecap joint. To be honest with you, she was in her 40s, and she came in with an MRI report, and the MRI said a medial meniscus tear, and her pain was not along her medial meniscus. And so we went through that discussion, and she ended up going somewhere else for a second opinion, which is fine. Encouraged, of course.
Always encouraged.
Yeah. And she had her meniscus trimmed. And then she kept having symptoms. And then she had it trimmed again because another MRI showed, it was
Still
another
had
tear.
signal, sure.
Yeah. And so what happened was she was in varus alignment. And varus means that the person's bow-legged. Mm-hmm. So like think of a cowboy sitting on a horse, their legs kind of bow over the side. Mm-hmm. And so for the audience, that obviously that pushes the force through the inner side of the knee where now you no longer have a meniscus. And so you can imagine what happens to that. So if there's no meniscus, the alignment causes even more loading across the inside, and then you have arthritis change. And it can happen pretty fast, honestly.
Right. Especially if part of it's been trimmed out. Mm-hmm. And you bring up a great point, right? And that's the I guess challenging but also a beautiful thing about what we do. That's the detective work that we have to kind of parse through and understand, right? So if a patient has bad bow-leggedness or bad varus and all that weight's being transmitted to the inside part of their knee, well, their meniscus may be degenerating because of that. So by you going in and trimming out part of it, you're just speeding up the process. Now they've lost more meniscus, and their medial compartment's going to get more arthritis. And so, understanding how that pathology works, and in contrast, a patient that has perfectly normal alignment, but maybe they tore their ACL 5 years ago, and they are now developing meniscal issues. Well, their solution may be to give them an ACL to stabilize their knee, take the load off the medial meniscus. And again, we'll get more into that, but that whole idea of what led to the problem in the first place is really important to understand. And sometimes we may not know, but we typically have a pretty good idea.
Yeah. So I'm going to tell you one more story.
Yeah.
And it's about my knee, because I think I heard it in fellowship doing some sort of like Rocky jump roping or something, with the music playing. But so I stirred my knee up, and then it got better, and then it started hurting again, and I MRI, and it was hurting pretty bad. Yeah. And so I got an MRI, and I had a medial meniscus tear, and I'm really bow-legged. And I saw it's the tears along the underside of the meniscus on the tibia side. And I looked at that, and I was like, oh man. And I was bow-legged, and I was like, I'm not touching this meniscus. I don't care how much. And then I just sort of like ignored it, and it got better. But
right.
But I had symptoms for about a week and a half.
Yeah.
And so in my mind, I'm thinking, somebody shows up at the doctor's office with certain meniscus tears you have to fix right away. But this one was bothering me, and ultimately it calmed down. And if you had gone in there and trimmed my meniscus out, who knows what my knee would look like right now. So very specific situations, it might make sense to not get too aggressive at first.
Sure.
And there's other situations where you might need to, and we'll definitely talk about that.
And again, the research continues to come out, gives us more and more insight into which ones can be kind of safely trimmed out and which patient populations. But the most common orthopedic procedure performed in the United States,
partial meniscectomy.
Partial meniscectomy by a relatively large margin, I believe. So
it's something like 100. Maybe like 500,000 or something. I can't remember.
It's a lot.
There's a big chart. Yeah.
So
do you find that there's any clinical exam findings or a history that suggests a meniscus tear better than others?
Sure. Well, one that definitely concerns us is the mechanical symptoms. Yeah. So almost any knee pathology, if you're coming to see us in clinic, you're going to have pain. Everybody's got pain, and that's part of the reason why you make the appointment to go see a doctor. So pain can be, sort of helpful, but not always. Mechanical symptoms also can be helpful. A little bit more so, I guess, than pain in determining whether or not a meniscus is truly symptomatic, in that if the knee is catching and locking, if you feel like it's getting stuck in a certain part of your knee, like, that almost feels like there's something in my knee and I have to shake my knee around and get it to pop and release, that to me sort of indicates a dynamic problem, something that doesn't always happen, and now it is happening on certain instances. So that can kind of key me in. Now, The other challenge is if you ask a patient if their knee is catching, locking, and popping, and they come in with a lot of pain, they're almost going to tell you yes, no matter what, right? And so you kind of have to tease it out.
I'll say, is it a pain? Like, does it hurt when it pops? It's
Right.
sort of like what I ask to try to figure it out.
Well, that's really important because
Yeah.
popping, kind of this crepitus, popping, whatever you want to call it, if it's painless, can be very, very normal. I mean, a lot of our joints in our body make audible noise, and it's not a problem at all. And so popping is certainly by no means always pathologic. It just depends on what the accompanying symptoms are. So that's important. One thing I found for the medial meniscus, and this may have been looked at, I'm not entirely sure, but in fellowship, one of my mentors kind of pointed this out to me and was like, this is always kind of almost a slam dunk medial meniscus problem, but the nighttime pillow between the knees. So we have patients that have these relatively, skinnier legs, skinnier knees, and so if you're sleeping on your side and the two knees touch together, basically you have the medial meniscus on medial meniscus in each knee. And they'll say, oh, yeah, no, I have to put a pillow between my legs because I can't have my other knee resting directly on my knee like that. It's too painful. So that one's been pretty helpful. But, yeah, I would say mechanical symptoms. And then, again, location of pain is important. If there's a patient that you're sort of on the fence about, they kind of have global symptoms and they have the MRI that shows a medial meniscus tear and they're kind of like, it kind of hurts everywhere, versus the patient that comes in with the MRI that says medial meniscus tear and they go, doc, it's right here.
I love it.
It feels
I love
like
it
an
when
ice
they
pick is right there in my knee.
When they do that, I'm like, we're gonna make you better.
We can get this better, right?
Yeah, the global thing is very hard to figure out sometimes.
Right.
I do think I have noticed the whole pain at night when you sleep. Your knees are on each other.
Mm-hmm.
I feel like that. I think that's a great point your attending made. I feel like that might be more just a compartmental type problem.
Correct.
Because
people, right?
People with arthritis of that side of the knee seem to complain of the same thing as well.
Right.
Okay.
Right.
Yeah.
No, you're totally right. Exactly.
So for me, with my tear, I had no joint line symptoms. I had no mechanical symptoms. And the thing that bothered me the most was actually trying to get my knee straight.
Oh, interesting.
So I asked that question now, and I think it's because my knee was inflamed and the capsule in the back of the knee, as my knee would straighten, the back of the knee would stretch, and it would hurt. And that was the thing. That was the main thing. I was like, gosh, it hurts to straighten my knee out.
Yeah, that's interesting.
And I was like, smashing my joint line, with
right,
my,
like
and I
not,
could, I was like, gosh, I couldn't make it hurt on the joint. So that's why I asked that question to see, what you thought, and I've found that they can hurt on the joint line some, but I don't find it personally very specific. Maybe the literature disagrees with me on that, but I haven't found it super specific. But the really bad tears where the tissue's literally flopping back and forth, those tend to be a lot more obvious, like the knees locking up, they can't get the knee straight and that kind of thing.
Well, one quick thing I'll add to that. So that, again, part of the challenge or art of what we do is that, let's say you have a pathology in your knee, the medial meniscus, and it starts off as medially based pain and you have some mechanical symptoms. Well, as soon as you develop a big effusion, which is swelling in the knee, basically fluid, water on the knee, the proverbial water on the knee, once you have an effusion, then at that point, really any motion can be painful. So going into deep flexion, patients will feel limited with their ability to bend, and then it's going to create pain in the front because the capsule is being stretched. In contrast to that, if you have a problem and you're guarding your knee for quite some time and you haven't fully straightened it, and that might not have been your case, but in some patients they can develop hamstring tendonitis, posterior capsulitis, and so now you have posteriorly based pain.
Right.
But it's because your meniscus has been pathologic for the last 2 months, and so now the whole picture becomes kind of cloudy. And again, that's kind of what we do as clinicians.
I feel like that happens a lot if the symptoms have been going on for a long time, like that you're limping around. My other orthopedic injury I'm dealing with right now is my broken little toe, and so I've noticed that my calf is getting achy, the other muscles in my leg are getting achy, and that was after only a couple weeks of just like kind of limping around from my broken small toe.
Right.
A horrible injury, but I use that in context to think, okay, so if I had a meniscus tear, something pretty substantial, and my whole way of moving around is so jacked up that like my whole leg just starts aching, and then you finally like, I need to go to the doctor because this is not good. Right. And then you show up and they ask you all these questions. You're like, oh yeah, the whole thing pretty much hurts, doc.
Right.
And then the doc's like, what is going on?
Exactly. I mean, that's exactly right.
Right.
That's exactly how it is. And at that point, everything is hurting. Right?
Yes,
and you don't even know where to
everything.
begin. So.
Okay, yeah, that's kind of fun to go over with you. So, Okay, so to help definitively diagnose a meniscus, or let me ask you this: what's sort of your imaging? Like, what do you do for imaging? Patient comes in, how do you start? Where do you go?
Yeah, so I mean, almost with every new patient, I'll obtain X-rays. I think looking at the knee on X-ray is very, very helpful. You'd be surprised at what we can detect on X-ray alone. It's really important to understand how much joint space a person has left, and then also to look at their overall anatomy, what their alignment looks like, what's the shape of the bone. Some patients have, bigger and smaller femoral condyles, and the shape of the top part of the shin bone can be different. So that's very, very important. And ultimately, an important part of this is, in our world as sports medicine docs and knee repair surgeons, so to speak, the quote unquote die has been cast when the patient develops arthritis. So if a patient has end stage arthritis and you go evaluate their meniscus, they're for sure going to have some type of meniscus pathology. And again, we don't really know, did they develop the arthritis because the meniscus had torn at some point, or were they going to develop the arthritis no matter what? And that's kind of leading to the meniscal damage. And so that's important to see. And you'd be surprised, especially in patients that have had trauma to their knee, they can have a fairly degenerative X-ray or radiograph, even if they're in their 30s and 40s. And so if I have a patient that has medially based knee pain on the inside part of their knee, and I'm thinking it might be a meniscal tear, we get our X-rays, and I see that they have end-stage bone-on-bone arthritis, well, we're going to not get an MRI. It kind of, it's already, the die has been cast. We kind of already know what the issue is, and regardless of what the meniscus is doing, we can't go in and predictably fix the meniscus in the setting of arthritis and improve their symptoms and outcomes. And that's been demonstrated extensively in the literature. The options are really, really limited once the compartment has gone on to severe or end-stage arthritis.
Mm-hmm. Yeah, I find X-rays very helpful at first as well. And if the patient's on the younger end, let's say 50 years and younger, I'll often add those alignment X-rays. And so again, alignment X-rays, essentially an X-ray from the hip all the way down to the ankle. Mm-hmm. And then if you draw a line from the center of the hip all the way down to the ankle, you can sort of extrapolate, okay, where's most of the mechanical load passing through the knee? Mm-hmm. And that helps me understand sort of what happens to the knee, like with every step, mm-hmm. and also helps figure a few things out, because I might, if somebody's really knock-kneed, the opposite of being bow-legged, then I might be more inclined to trim out a beat-up medial meniscus tear if most of their weight's going, maybe not, or substantial parts passing through the other side of their knee. Right. I actually think there's a study about that where patients with, I can't remember the type of meniscus tear, but they had a medial, maybe it might have been a root tear, and if their alignment was 2 degrees more into the other compartment or more, mm-hmm. This older age group, maybe 50s or 60s, they did just, they were okay.
Interesting.
They ended up, so I sort of like eyeball that to kind of see what the options are. And then it also helps you say, hey, look, you have a meniscus tear. It's on the side where your mechanical load is passing through, and I can draw the little yellow line on the mm-hmm. X-ray machine. Mm-hmm. And I say, if we trim this thing out, your shock absorption is not as good here, and we could maybe run into problems. And they're either like, okay, that at least they understand what could happen down the road, which is, I definitely get people who come in and they don't have that explained to them. Right. And they're like, I've got all this arthritis. They're upset, and
it's hard. It takes a long time. And again, I mean, we've, been talking through it here, and obviously we kind of understand the anatomy and the pathophysiology, and then you've got 15 minutes with the new patient trying to explain to them, hey, this is your alignment, your mechanical access. Every time we take a step, loads are transmitted from the center of our body down to our hips, knees, and into our ankles. Depending on where your knees lie in space related to our hips and ankles, it can affect how the load, I mean, it's complex. And then you get into the meniscus anatomy and the blood supply. And as we age, and this is an important thing, so as we age, as with most parts of our body, all the parts of our body essentially, we see aging effects in the meniscus. So the meniscus is, like we've talked about, primarily collagen, type 1 collagen, but it's actually a high percentage of water. So there's a high water content in the meniscus, and then it's other proteins and sugars and things like that. And again, fibrinous material. So as we age, we lose the density of those proteins and cells. We lose water in the meniscus. So overall, the overall health of the meniscus as we again age goes down. And so that's an important thing. And you try to explain that to a patient that's maybe they're in their 50s, but they're very, very active and they play tennis and swim and play sports and exercise. And so in their mind, they're like, well, I feel very young physiologically, and they very, very well may be. They may be very, very healthy, but no matter what, the meniscus is going to be a little bit different than it was when they were 20. And so the healing potential may be different, and how you ultimately treat that patient may be different. And that can be a hard thing to explain in 15 minutes.
Yeah, absolutely right. But it's important, It helps people make educated decisions, and it helps a lot with dealing with frustrations down the road as well. So if you suspect a meniscus tear, are you always getting an MRI, or like what do you do with that?
Yeah, I mean, I think MRI is still our kind of gold standard for imaging the meniscus. CT arthrograms for some patients that have, metal in the body or can't get an MRI, those can be a little bit helpful, but they're certainly not as high quality. And as the MRI magnets get stronger, just to kind of, for the lay listeners out there, CAT scans or CT scans are like a radiation type of imaging similar to an X-ray, and MRI uses a magnet, and the magnet excites the electrons, and as they kind of fall back down to Earth, they create an image. And so now that the magnets are getting stronger and stronger, the detail and the quality of images that we're getting back from the MRIs is only going up. They're starting to plug them into three-dimensional software. And so, I think in the next 15, 20 years, MRI is already the gold standard, but it's only going to continue to get better and better. I think for me, I have a relatively low threshold to get an MRI if the patient has already failed a lot of things. And so I really do think a majority, especially the degenerative type. Now, if a patient comes in with an acute injury, hey, 3-4 weeks ago, I felt a pop. My knee got really, really swollen and big. That patient, and they're active and relatively high demand, should kind of get an MRI no matter what. Because you don't want to miss something and then they lead to more damage in their knee. And another thing with that, you have to understand, as a surgical subspecialist, we're often the second or third person they're seeing down the line. They may have already gone to the ER. ER sends them back to their PCP. PCP sees them and says, oh, your knee still hurts. You need to go see an orthopedist. And now it's been 6-8 weeks. They've tried to do some gentle rehab. And so, at that point, you're kind of the end of the line. And if everything else that could be worked up has been worked up, you should get the MRI. Because, again, this is with the goal of preserving the longevity of their knee and keeping them active for as long as possible. So definitely the acute patients with acute pain and swelling, and then the patients with more maybe chronic symptoms. If they've tried everything else, doc, I've been trying to change my activities. I've rested it. I've iced it. They put me in physical therapy for 2 months. I did my home exercises for 2 months after that. My knee is just still killing me. If they don't have an MRI yet, to me, it's kind of a no-brainer. And you'll never know what you'll see. You could see the cartilage surfaces. You could see the meniscus for sure. You could see the ligaments around the knee. You can see how much fluid is inside of the knee. So the MRI gives us a ton of information. Yeah,
that classic finding of joint line tenderness. Well, the joint line is like this big,
Right.
It's like 3 times... My finger's like 3 times as wide as the joint line, so I start pushing on the joint line. Am I pushing on the bone that hurts? Am I feeling grinding over the joint line because they sheared off some cartilage that's not the meniscus? There's all, like you say, there's all sorts of things that it could be. It's just everybody's like joint line tenderness equals meniscus, and maybe so for the most part, but it's not always that straightforward, honestly. And I agree. If you have a young, physiologically active person whose x-ray looks pretty good and they come in with a ballooned up knee after an injury, they are getting an MRI. Yep. I don't really feel, honestly, like if your knee's that blown up or even has some fluid in it after an injury, what is that likely to be? Blood? Yeah. Well, then we better figure out, what's going on in the knee, And so, fortunately, I haven't had too much pushback from insurance companies on that. But
yeah. For me, swelling in a young patient is always pretty concerning. I mean, even without an acute trauma, if a patient comes in and they're in their 20s or 30s and they're active and they say, I don't know, for the last 2 or 3 months, my knee just like blows up huge and I can't put weight on it. I can barely bend it. It hurts so bad. That to me is concerning. I mean, there's something, the homeostasis of the knee. I guess one thing we didn't really cover. So the knee, when we talk about water on the knee swelling or effusions, our knee has a lining all around it, and we've kind of alluded to it with the capsule, so to speak. But that capsule extends maybe 3 or 4 centimeters above the top of the kneecap, or it depends on the position of your knee, but kind of above the kneecap and down towards where the patellar tendon inserts, sort of. The reason why I'm explaining it like this is because if there's fluid inside of that capsule, that typically means it's a problem inside of the knee, so an intra-articular problem, and those types of problems can lead to other intra-articular problems. So different than something like an extra-articular tendonitis or a muscle strain or something like that. And so when I see big swollen knees with fluid that seems like it's coming from deep inside of the knee, especially in a young active patient, those are getting MRIs in my hands, 9 times out of 10. Because I don't want to miss a problem that I can fix or that we at least need to know about that that could lead to long-term issues.
For sure. All right, great. So what types of so you get the MRI scan. Okay, we've got let's just say an isolated meniscus tear, not one associated with an ACL tear or other ligamentous injury. What meniscus tear are you saying we got to go fix this? Like, we're not going to go NSAIDs therapy, whatever. Yeah. Which ones are you like, we got to go?
So, I mean, it's always sort of ultimately a game time decision. And what I mean by that is an intraoperative decision. So we typically treat meniscus pathology with what's called arthroscopy. So minimally invasive surgery. We put 2 poke holes in the front of the knee, put a camera and instruments through those poke holes, and then can look all around the knee and again, perform the kind of 12-point inspection. At the time of surgery, we look at the location of the tear, the tissue quality, whether or not we think the blood supply to that area would be good, and then sort of determine whether or not we fix it. Now, certain types of tears pretty much get fixed exclusively. Root tears, I think we all kind of agree as sports medicine surgeons, especially in active populations, those should be fixed. Big radial tears, those should certainly be fixed. But the other types of tears, there's some nuance to whether or not you repair it versus do a partial meniscectomy and trim part of it out. An important thing that we've touched on a little bit but haven't gone into much detail about is the blood supply. So part of and under the same umbrella of as we age, what changes with the meniscus. So again, the water content changes, the amount of proteins in the tissue, the density of the cells in the meniscus can change and go down, but also the blood supply kind of retracts. And so the meniscus receives its blood supply from the periphery. And again, they're C-shaped, so all the blood supplies are kind of coming from the outside, the blood vessels. As we get older and once we finish growing and developing, they kind of start to regress away. And so the most inner aspects of the meniscus, kind of towards the center part of the knee, has the poorest blood supply, and it only gets worse as we age. And so if you have kind of oblique tears in that area, tears that kind of create a small flap of just the innermost part of the meniscus, well, that is probably not going to heal if you fix it. And so if you're trying to relieve a patient's mechanical symptoms or get rid of a flap that's kind of going in and out of the knee and putting pressure where it's not supposed to, trimming that type of tear out makes a lot of sense. Otherwise, if the blood supply is good, if the tissue quality is good, and the patient's relatively young, I'm fairly aggressive about fixing them and trying to save the meniscus, quote unquote.
Yeah, I tend to be pretty aggressive. If the cartilage in the knee looks good.
Oh, that's a huge part of it too. I didn't touch on, right? So the cartilage has to be intact. If the cartilage is not in good shape, then
I feel like I've always done this, but it's probably been an evolution. But if somebody is, again, the term physiologically young, like their cartilage is good and they have a pretty bad meniscus tear, plan A, B, and C for me really is to fix it, and I'm willing to accept the chance that it might not heal to try to preserve that meniscus function. And I think there is some good data, I believe, that even in like 40s and 50s, you can still have healing of the meniscus despite older age groups. And so I do take that into consideration, but it's a discussion. I say, hey, look, This is how we treat a meniscus surgically. We either trim out the torn tear or we can try to fix it. And if this tear like really involves a significant part of the meniscus that's going to affect you mechanically, are you willing to put up with rehab for a long time, for this type of thing?
Mm-hmm.
The other thing that I was alluding to with that question was, are there types of tears where, like, if you see it on the MRI, so like a radial tear or what we call a bucket handle meniscus tear,
Right.
Are those types of tears where you see that and you're like, oh, you know what?
Right.
Let's look. We have to go in and we've got to do. We can't treat this non-surgically first. We really need to go in and fix this right away.
Yeah, I mean, definitely acute bucket handle meniscus tears, and we see a fair amount of those in our athletic population. Lateral meniscus tears in general, because the lateral meniscus is smaller, and again, the proximal tibia or the top of the shin bone is a little bit more convex, so the lateral meniscus is probably more important than the medial meniscus if you just wanted to take all things considered. I tend to be more aggressive with those, but sometimes we see the, patient in their 60s that had an injury when they were 18, 19, 20, where they had a bucket handle medial meniscus, and somehow they've just dealt with their knee for 40 years. And then finally, whatever it is, the straw that breaks the camel's back, who knows? Now their knee is swollen, and then we get MRI, and it's like, oh yeah, this bucket handle. And then like, I haven't injured it since I was 20, and then you go in with the scope, and it's degenerative and old, and it's like desiccated, so it's all dried out and just kind of doesn't look healthy at all. And you feel bad about trimming that out, but you have to. I mean, putting stitches in it's not going to heal, and so you have to use your judgment as a surgeon.
When they're popped out, I've got a video that I'll put a link to it on this podcast episode, just showing exactly what a bucket handle tear does in a model. But like when it's flipped out of position, it also maybe that's what you meant by desiccate, but like it shrinks up and you literally can't push it back in place.
Yeah.
And then you just got to take it out.
It doesn't even move. Yeah, it's stuck.
Yeah. And then I've had another guy, I can see his face right now. He had like a lateral bucket, maybe it was lateral. I can't remember, lateral medial, but it would pop out, meaning it flipped out of place. His knee would lock, and then it would flip back in place, and then he was like, fine. Mm-hmm. And so when we ultimately went in to fix it, he had been dealing with this for years and years, by the way. And but we went in to fix it. I think it was because it kept popping back into its normal anatomical position. It never went through that degenerative wearing out process, and it was repairable.
Well, it just goes to show you how little we still know, right? I mean, we have PhDs all over the world, and scientists at some of the greatest institutions on earth, and we're still learning so much about it. There's still so much that we don't know. Which ones, preserve the integrity and the quality of the tissue versus. But that hypothesis makes a lot of sense. Yeah, if it gets back into its normal position and spends some time there, maybe it's getting some, I don't know.
Right. And then I guess it's a good time to talk about technique, because there's minimally invasive techniques, and then there's ones where you got to put cuts on the knee. Right. Let's go over some of that stuff.
Right. So again, when we do knee arthroscopy, this is kind of an important thing. So typically we start with two, and I don't know if this model is going to show up well on the screen, but I'll try. We typically make two poke holes in the front of the knee, kind of one on the inside or one on the outside and one on the inside. Those two access points are great for doing a diagnostic, looking all around the knee and getting an idea of kind of what's going on, but they're not perfect for fixing everything you need to fix. And as you can imagine, if there are some pathologies or tears of the meniscus that are more towards the front, it's hard to go in through the skin and then like kind of come around the corner and access the front of the meniscus. So there are some cases, like you're kind of getting at, where we make accessory incisions. We kind of go from the inside to the outside part of the knee, or even coming from the outside back to the inside part of the knee to get a more comprehensive repair of the meniscus. The cool thing is that, again, now that we're getting further into the future and technology advances, our implant companies are making new specialized implants that have curves to them, that have special bends. You can even bend them even further, and they can do a bit more. So we're trying to minimize the number of incisions that we need, but ultimately, and I think you would have the same philosophy, we're going to do whatever we have to take to get it perfect. That's it. If I have to make an extra incision, I'm going to do that. I think exclusively 100% of my patients would not mind a small extra scar if that means I can get a good repair on their meniscus. That's just part of it. Yeah,
I think about it the same way. Is there any are there any types of tears in particular you do make those incisions for? But what we call inside out
Sure.
repairs?
Yeah, I think lateral meniscus bucket handle tears are an easy one to use as an example. Again, the lateral meniscus is a little bit smaller, but there's a tendon in the back part of the knee that's inside of the knee joint. It's called the popliteus tendon, and the lateral meniscus doesn't really have any connections back there, and so how you plan your stitches for a bucket handle lateral meniscus tear can get kind of tricky, and especially coming around towards the front, there's also the peroneal nerve in the back and other bad stuff, and so as you sort of work your way from front to back, having that accessory incision to do an inside-out, outside-in type repair is very, very helpful. What's your philosophy? Is that one that you'd also...
Yeah, honestly, if I get a bucket handle, I like putting a lot of stitches through it to make it really stable. So I would have to be convinced, but I typically do inside out for big bucket handle tears, like you say. The needles we use aren't as big as some of the other devices, and you can be a little bit more versatile as to where you put the stitch to kind of get the meniscus lined up exactly where you want it. And I do like you said, the cannulas let you kind of really sneak those needles around to different parts of the meniscus. So like a bucket handle for sure. Also like a radial tear. So like here's the C, and we cut the C like this. I will often do an inside out for those, just for that versatility of getting a lot of stitches through to hold that in place.
Yeah.
Let's see what else. If you do a meniscus transplant, where like if you actually like take a human donor meniscus and put it in the knee,
that could be a whole podcast in and of itself.
Yeah, that's a little bit different than this, but I think I use
that certainly needs a bit more. You need more tools in the toolbox.
Yeah, I think those would be the main ones.
Yeah,
honestly,
for some of the radial tears I've treated that maybe are close to the periphery but don't go all the way. I've had some success with doing all inside, but the location is everything.
Yeah.
All inside, where we don't make the extra incisions on the other parts of the knee, relies on a fixation point, and typically the implant companies either use an all suture or like a medical grade plastic to anchor the sutures to the capsule portion of the knee. And that can be great because it saves the extra incision, but you really have to make sure the tear is in an appropriate place to then put that device into the capsule. If the little medical grade plastic piece or the little suture ball doesn't catch the back of the capsule, it's not going to do anything, and it's going to fail.
Yeah, sometimes it's hard to feel because so imagine to the listener, you're looking from front to back in the knee, and you're following this needle to the back, and you're pushing through the meniscus, and then you have to feel it pop out the back of the knee, and sometimes it's a little hard to feel that exactly.
For sure.
And if you're in certain areas, the artery is like a centimeter behind you.
Right.
There's
bad stuff.
You gotta make sure you know what you're doing. That's for sure. So I guess we should talk just real quickly, like ligament injuries plus meniscus tears. I want to say, correct me if I'm wrong. You've been to a grand rounds much more recently than I have, but the association of a meniscus tear with like an ACL, like in an athlete, is like 50% of the time. Does that sound about right?
Yeah. I think of all meniscal tears, about 30 to 40% are associated with the concomitant ligamentous injury, which is a lot, right? And so I think more frequently, I think what am I trying to say? With really bad knee injuries, we have this thing called the unhappy triad, where it's ACL, MCL, medial meniscus, and then people kind of think about that. But more commonly, I believe the lateral meniscus is the one that's actually torn. The good news is for patients that in the setting of an ACL reconstruction, meniscus repair has a higher rate of healing. And we hypothesize, and kind of makes sense, that it's because we have to drill new tunnels to create the new ACL. So if a patient, and again, we don't want to digress too much, but if a patient tears their ACL, the gold standard is to give them a new ACL, an ACL reconstruction as opposed to an ACL repair, but that may be changing in the next decade or two. And to create the space or the quote-unquote docking sites for that new graft to come in, we drill legitimate tunnels about 1 centimeter in diameter through the thigh bone and through the shin bone. Because we drill those tunnels, it allows the bone marrow elements, growth factors, blood, all kinds of stuff to enter the knee and perhaps help augment or improve the healing of the meniscus. So although meniscal tears are common in ACL injuries, the good news is when we are in surgery and we fix them, they have a little bit of a higher rate of healing than just an isolated meniscus tear alone.
Yeah. And usually these ACL or other ligament injuries, if you're doing something with the ligament, the patient's going to be on the younger, more active age of things. And so you're
Right.
also, so
That's a good point.
yeah. So, you know, you go in and it's not just an ACL surgery. You just go in and do a quick ACL surgery or something. Often fixing the meniscus takes as long as doing the whole ACL surgery.
Yeah.
And often they'll have the medial and lateral meniscus
Both
torn.
sides, yeah.
And so you're doing 3 surgeries really
Right.
with an ACL surgery because of the
Yeah.
other injuries. And then like we mentioned earlier, the ACL provides that stability to the knee, but the meniscus also provides stability to the knee. And just getting ready for this podcast, at first my impression was that if the ACL is torn, then the meniscus kind of is second in line. But I want to say, even if the ACL is intact, there are certain situations where the meniscus also offloads the ACL a little bit.
Yeah. Well, it seems like especially in deeper flexion. So as the knee bends more and gets into deeper flexion, the medial meniscus seems to show a higher or more important role in preventing the shin bone from moving abnormally. And again, the medial meniscus we think sort of helps to prevent anterior posterior translation, again, especially in deeper knee flexion, whereas the lateral meniscus may have a more important role in rotational stability, but they both play a very important role in stability in general.
Yeah, so absolutely. And so when I get these cases, I want to fix everything because I want to make the knee as normal as possible. And I don't want any extra load on that ACL graft. So I don't want it stretching, I don't want anything. I want the knee behaving just like it's supposed to behave. So you know, you spend all this time fixing the meniscus, and then, oh, by the way, we have to do the ACL as well. Right. I gotcha. Okay. Yeah. So, man, we've covered a lot of stuff. We good on time?
I'm doing
You're
great,
good?
man.
You're
This
good
is
on
awesome.
time?
Yeah, I'm enjoying this conversation.
Yeah. So let's see. So,
we did some treatment. We could talk about some rehab at some point, but
yeah. That's actually. Let's talk about rehab for a second. That's a big difference. You know, somebody who trims their meniscus out. You know, you get the pro athlete. They had a meniscus tear. Now they're playing 3 weeks later.
Yeah.
What's up with that? Are they getting magic surgery, or is something else to this?
Yeah, well, you know, when we do a repair as opposed to partial meniscectomy or trimming it out, we tend to slow down the rehab a little bit. And every surgeon is different. Every surgeon's rehab is different. But for the most part, you know, we may limit the weight bearing. We may limit the amount of flexion we allow them to do early on. With just a quote-unquote trim-out procedure, there really is no restriction. We let them start walking immediately. They'll need crutches maybe for a week, maybe 10 days. They get down to 1 crutch and then no crutch. I personally don't have any range of motion restrictions on my patients, and so as soon as they're ready, they can go. With the repair, again, because the rehab is slower early on, the goal of that is to allow the meniscus to heal. And so we don't want a patient, an athlete, theoretically, or a patient, right, if they're a recreational athlete, going back to sports or activity too quickly and then compromise that repair. So it's a bit more of a fragile situation, but we're also, in theory, preserving the long-term health of the meniscus and the long-term health of the knee because we repair it and we can save that piece. But certainly, yeah, I mean, in some athlete circles and whatever types of forums and places you may go, some athletes may demand a trim out procedure and they don't even want to have it fixed. They say, hey, I got to get back. You know, championship is coming up. We've got 6 weeks left of the season. I got to go. And so those situations are just conversation. It's always a conversation, and it's a patient surgeon decision that we make together. Ultimately, the patient makes the decision, but we provide the information and the kind of guidance to get to that decision. So it's certainly a shared decision making process.
Yeah, I guess an important thing to consider is the something called the reoperation rate after fixing the meniscus. So that seems to come up a lot when comparing partial meniscectomy with an actual repair. So so you repair the meniscus, but there's a higher reoperation rate because potentially, I believe because if it doesn't heal, you might have to go in and trim it out, or something along those lines. And so that's but that's not a big deal in terms of like technical, to do that technically. You know what I mean? They would just, it's not like they would. it would result in a significant amount of downtime or surgical risk for that type of procedure if you try to save somebody's meniscus. But perhaps that factors into an athlete's decision. Well, if it doesn't heal, then I'm gonna have to go back and get it trimmed again, But I've had some athletes who are like, no, I want my knee, I want my meniscus. I've read about it online. I don't want it trimmed out. I want you to try to fix it. I've had it go both ways.
And
Definitely.
again, it's going to be the correct answer for every patient is going to have all these elements that are factored in. So it's kind of different for everyone. But
I feel like I have all these stories to tell you because I just thought of another one.
No, go.
Okay,
Share.
so let's. This isn't the same lady. This is a different patient. I had another patient come in. She had a root tear, and so root tears. The rehab for that is even more challenging, but for her, she did not want to go through the rehabilitation for the root tear. So what I do is if the meniscus is torn off the bone at the root and you repair that, I typically keep them non-weight bearing for 6 weeks. And she just did not want to deal with that. And she was maybe in her late 40s or so, but she had good cartilage in the knee. She did not want to deal with the rehab. I'm not kidding. 9 months later, bone-on-bone arthritis to the knee.
Did you end up doing anything or no? Did you do
She wants a uni.
Well, did you end up taking her for a partial meniscectomy or anything? Or
well, no, because she's slightly varus aligned, so she's slightly bow-legged aligned.
I see. So she just left it. Is it kind of elected?
Yeah, it was like, well, so as you know, but for the audience, so like if you go in and trim the meniscus, the whole idea is you have parts of the meniscus that's torn, it's unstable, it's painful, causing symptoms. And so you can trim that to a stable margin. You can get rid of that unstable, painful segment. But if the root is torn, it's just kind of the root. You can maybe trim the root out, but it's not quite the same situation. Yep. You know what I mean? And so, and I think those patients just don't. You go in and trim it up, but it doesn't make any difference. They still have pain, especially if they're bow-legged.
Yeah.
And so, so I bring that up to bring the to note the point. Some people might be like, okay, fix it. I'll do the 6 weeks. She just didn't want to deal with it.
Yeah.
And now she's got unfortunate arthritis because she didn't want to deal with that now. So, but that was her personal decision.
Exactly.
And we talked about it, right? But that's something to consider.
Well, and it's hard again, and I don't know what the specific circumstances were for that specific patient, but people have to work. They can't stop working. They have young kids they have to take care of.
That's a big challenge.
They live alone, or they have to take care of their elderly parents. And if they say, "Hey, listen, it doesn't matter," flat out, it's either if I can't be walking on this for 6 weeks, I cannot do the surgery, and it's just not going to happen. And those patients exist, and you say, "Hey, listen, we have to keep a close eye on it. You're probably going to have a progression of arthritis. I don't know how fast it's going to happen. It could happen in 6 months or 6 years, but." Just know your knee is at risk, and if they understand that, and you make your recommendation, and it just unfortunately that's just part of it. I mean, the good news is we now at least have the ability to diagnose it. I mean, you think 100 years ago, 150 years ago, right? Wouldn't have even known. So we're getting there. We're getting there. Maybe one day we'll have a way to do root repairs and allow them to weight bear early.
Yeah, I'm sure there might be some other surgeons out there who get really aggressive with it, but I mean, if you're going to go through the effort of like really repairing it, unless I see some. Maybe the study exists, maybe I haven't seen it, but when you put these stitches through this meniscus, this isn't like giant, super strong cables. I mean, these are typically kind of thin-ish stitches, and the weak link is often the tissue, and the stitches, no matter how many locking loops of the stitch you can push through it, all that mechanical load is going through that root. Right. And so you're going to do that, you might as well protect it. And
we rely on it to heal. So, a question that patients commonly will ask, they'll say, do the stitches dissolve? Do they ever go away? What happens? And I have to tell them, I say, no, I don't want them to dissolve because I need them to be strong enough to let your body heal the tissue. If your body never heals it, everything has a failure point. Every material on earth, to some degree, with enough loading will fail. And so if your tissue doesn't heal back down to the bone, it's going to fail. I don't know how long. Maybe it'll last 60 years and right through the rest of your life. But no, it's critical, right? And so between the quality of the tissue's ability to heal, where we put the stitches, I mean, we are trying to create an environment that over the next 6 weeks, 8, 10, 12 weeks, your own tissue will heal back down to the bone. That way those sutures can stop seeing load, and eventually everything can kind of become inert. That's the goal.
Right. Do you is your rehab similar for radial tears?
Yeah, so
6 weeks?
my root and radial tear is actually on the same. It's on the
Yeah.
same. It's on the same page. I just circle whatever I did.
Yep. And then other types of tears, say the longitudinal tear, where it's cut. It's hard to describe.
I know
on
it's
a model.
a three-dimensional structure. Right?
Yeah, I'll put a link to my video on it. But the so it's just kind of cut, and then you kind of cut it around, so it's kind of cut in this direction on the meniscus. What do you do for those?
So if I repair it, I'll still let them weight bear and extension. So those types of tears are nice because they sort of can kind of compress and stabilize themselves. You know, again, if we're thinking about the meniscus, there's C-shaped structures, so to speak, and as you walk, the hoop stresses go all around like a hula hoop. And so if there's a tear, and if it hasn't bucket handled out yet, and it's still well approximated, and you fix it, each time that patient walks, it kind of wants to close. But I'll only let them weight bear in extension to start. I wouldn't want them weight bearing in deep positions of flexion, because as you get into deeper flexion, you're loading different parts of the meniscus, and it just makes me a little bit nervous.
Yeah, I think that's really reasonable. My program is similar. I might start maybe like 25% and like slowly ramp them up or something like that. But there's I think everybody kind of rehabs that a little bit differently. But for sure, the weight helps. Adding weight through the knee doesn't cause strain across the tear.
Right.
In that position, that full straight position.
For that type of tear.
Right. You walk on a radial tear repair or a root, not good. Don't do that. All right. Well, all right, man. We covered a lot of material here today. Really appreciate you taking the time to sit down and go over everything. Yeah, we're already at. Oh man, we're an hour and 6 minutes. It felt like it went by fast. Went by really fast. But thanks again for the time. Hopefully this helps a lot of patients. So we'll have to sit down again soon.
Yeah, my little last thing would just be, if you're a patient listening to this, or even a provider, and you happen to have your own meniscus pathology, try to not let it, cause too much anxiety. We've really got some fantastic ways to treat these conditions, most of which are non-surgical. Not every meniscus tear requires surgery. Again, like we talked about in the beginning, some meniscus tears are totally incidental, right? We get the MRI, we see it, but ultimately it may not even be related to your current set of symptoms. And so as our medical records become more and more transparent, and as patients get more and more MRIs, if you see that you have a meniscus tear or again, intra-substance signal within a portion of the meniscus cannot rule out tear. If you see those kinds of findings on your MRI, try to stay calm, don't panic, just meet with your orthopedic surgeon, and he or she will take you through everything you need to know.
Perfect, man. Good public service announcements. Excellent. Thanks again, man. Yeah, all right.
This has been awesome.
We'll talk soon.
Great.
Or I'll see you in clinic.
Excellent.
Okay. All right, man. Later.